Imagine going through a highly sensitive medical procedure, one that promises to completely eliminate chronic intimate pain.
Right, something that's supposed to totally restore your quality of life.
Exactly. And for the first 6 months, it works perfectly. You are absolutely thrilled. But cut to 24 months later, and a staggering 75% of patients say that relief has just completely vanished.
Yeah. And worse, some are actually left with new, permanent structural damage.
Right, which is terrifying. So today, we are shining a massive high beam spotlight on the multi-million-dollar world of intimate and pelvic health. Because, well, the human body's remodeling process just refuses to operate on a flashy marketing schedule.
It is a reality check that is, frankly, long overdue.
Yeah.
I mean, we are looking at a space that has just exploded with technological advancements. Everything from, localized hormones and transvaginal lasers to electrical stimulation and surgical reshaping.
Yeah, but amidst all that innovation, there's a staggering amount of misinformation out there.
Oh, absolutely. Tons of it.
And that is exactly why we are doing this deep dive.
Welcome.
Our mission today is to cut straight through the marketing hype and the taboos. We are examining a stack of clinical guidelines, surgical protocols, ethical reviews, and massive troves of trial data.
Yeah, specifically focusing on treatments for genitourinary syndrome of menopause, urinary incontinence, and cosmetic gynecology.
Right, because we want to know the actual timelines, the physical realities, and what actually happens when you treat a complex biological ecosystem like a quick renovation project. So, if you are listening to this right now, I want to ask you directly, have you ever wondered what really works when it comes to intimate health?
And maybe more importantly, how long do these treatments actually take to show tangible results?
Yes. That timeline question is really the anchor for everything we are going to explore today. Because when we start looking at the foundation of intimate health, particularly, as the body ages, we run into genitourinary syndrome of menopause, or GSM.
Right, and GSM affects at least 50% of postmenopausal women. The sudden drop in estrogen leads to severe dryness, incredibly painful intercourse, and recurrent urinary tract infections.
Okay, let's unpack this. Why does a drop in one single hormone cause such a cascade of massive structural failures in that specific part of the body?
Well, to understand that, you really have to understand what estrogen actually does down there. Think of estrogen as the master architect for the vaginal tissue.
Okay, the master architect.
Yeah. It constantly instructs the cells to stay thick, highly elastic, and, well lubricated. It also feeds the healthy bacteria that keep the local environment acidic.
And that acidity is what fights off the urinary tract infections, right?
Exactly. But when menopause hits, the ovaries essentially retire. So without that architect giving instructions, the tissue rapidly thins out, loses its blood supply, and becomes incredibly delicate.
Which totally explains why the clinical guidelines are so adamant about the very first step in management, which is just eliminating irritants. Because if your tissue has lost its armor, suddenly everyday things become hostile.
Precisely. I mean, providers will advise patients to take stock of literally everything that comes into contact with the vulva. You have to look at the chemicals in your toilet paper.
Wait, even toilet paper?
Oh, yeah. Toilet paper, the artificial fragrances in the detergent you wash your underwear with, standard body soaps. If there are fragrances or harsh chemicals, you have to swap them out for hypoallergenic alternatives.
Because the tissue is simply too compromised to handle them without triggering inflammation.
Exactly. And beyond just removing the bad stuff, there is a really fascinating distinction made in the clinical pathways between temporary relief and actual maintenance.
Oh, you mean the difference between a lubricant and a moisturizer? Because if you are dealing with GSM, you really have to understand that physical difference. They are not doing the same job at all.
Not even close. It's a vital distinction that often gets mixed up. A lubricant is entirely short-acting. It just sits on the surface of the tissue to reduce friction immediately before and during sexual intercourse.
Like putting oil on a squeaky door hinge?
That's a perfect way to put it. It temporarily smooths the movement, but it doesn't change the metal. Vaginal moisturizers, on the other hand, are completely different. Products like Replens MD or Yes VM, they're designed to be absorbed deep into the tissue.
And you use those every 1 to 3 days, right? Even if you aren't having sex.
Right, to provide an ongoing baseline level of hydration.
So it's like soaking a dry sponge so it regains some of its flexibility. But, and this is a big but, while moisturizers help soothe the immediate discomfort, they don't actually reverse the underlying cellular damage caused by the lack of estrogen.
No, they don't. For that, the guidelines bring in the heavy hitter, which is local estrogen therapy.
Right. And local estrogen is fascinating because it comes in these slow-release vaginal tablets like Vagifem or specialized creams like Orthonginus.
And the mechanism here is just brilliant in its targeted approach. By applying the estrogen directly to the vaginal tissue, it stimulates the epithelial cells to mature again. It literally plumps up the topmost layer of cells by filling them with glycogen.
Wait, glycogen, that's essentially stored sugar, right?
Exactly. It fills the cells with stored sugar, which then feeds the healthy lactobacilli bacteria in the vagina, restoring the acidic environment that prevents UTIs.
Wow.
Yeah, brings the blood flow and the elasticity back entirely locally.
So is local estrogen essentially like applying a highly targeted prescription-grade serum to a very specific patch of damaged skin rather than taking a massive pill that floods your entire bloodstream with hormones?
That is a highly accurate analogy. You are delivering the biological building blocks directly to the site of the structural deficit, completely avoiding the systemic risks associated with whole-body hormone replacement therapy.
That makes so much sense.
But here is the critical catch, and it goes right back to our central theme, the timeline.
Right. It's not an overnight fix, not even close.
The clinical trials show that, well, while some patients might start to feel a slight reduction in discomfort in about 2 weeks, the peak physiological effect, the actual restoration of that cellular scaffolding we just talked about, takes about 3 full months of consistent use.
3 months just to reach the baseline. That requires a tremendous amount of patience.
It really does.
If you're listening and you've tried this for a week and quit because it, wasn't working, this is your validation. The biology just doesn't move that fast.
And crucially, it is a lifetime commitment. If you stop the treatment, the architect leaves the building again.
And the structural support vanishes.
Exactly. The painful symptoms will inevitably return. It is an ongoing management strategy, not a permanent cure.
Okay, so we know estrogen takes months to rebuild that cellular scaffolding. But what if you literally can't use hormones? Say you are a breast cancer survivor on estrogen-blocking medications, or you simply have medical contraindications. Are you just stuck relying on short-acting moisturizers forever?
Well, that is where the medical field had to pivot and look outside of endocrinology. When you can't use hormones, you turn to high-tech physical interventions. Specifically, you turn to energy and electricity.
Which brings us to a really intense area of clinical research,
Yeah.
transvaginal lasers. The medical literature details the use of CO2 and erbium lasers being utilized to treat GSM. And when I was reviewing the actual mechanism of how these lasers work, I honestly had to read it twice to make sure I was understanding it correctly.
I don't blame you. It is entirely counterintuitive at first glance. The laser device is inserted transvaginally, and it emits focused energy that rapidly heats the tissue of the vaginal wall. The clinical term for this is creating a controlled thermal injury.
Wait, we are intentionally causing a thermal injury, meaning we are burning the inside of the vagina? That sounds absolutely terrifying. How on earth does injuring the tissue actually heal it?
Think of it like a controlled forest fire. Sometimes, to clear out the dead brush and encourage new, vibrant growth, you have to introduce a highly managed level of destruction. So the transvaginal laser creates thousands of microscopic pinpoint burns in the tissue. In response to this sudden damage, the body's natural healing cascade essentially hits the panic button.
Oh, so it forces a healing response.
Right. It rushes blood, nutrients, and fibroblasts to the area, which stimulates the production of brand new collagen and elastin fibers to heal the wounds. The typical protocol involves 3 of these sessions, spaced out about 4 to 6 weeks apart, giving the body time to remodel between burns.
That is a wild biological workaround. But tell me it actually works, because if someone is signing up to have their internal tissue intentionally burned, the payoff better be monumental.
Well, in the short term, the efficacy data looks undeniably promising. Across multiple systematic reviews, researchers track patient outcomes using visual analog scales, which are basically those simple 1 to 10 rating charts for pain.
Right.
The scores for dryness, itching, burning, and dyspareunia painful intercourse show massive, statistically significant improvements. At the 1 to 3 month mark post-treatment, patient satisfaction is routinely incredibly high.
But there's always a but when we talk about forcing the body into an unnatural healing state.
Yes, there is. The long-term data paints a much more complicated and frankly concerning picture. There is a specific clinical case series tracking 184 patients that really highlights this.
Okay.
At 6 months post-treatment, patient satisfaction was an incredible 92%. But watch how it completely deteriorates over time. At 12 months, satisfaction drops to 72%. At 18 months, it's down to 63%.
Oh, wow.
And by the 24-month mark, only 25% of the patients were still satisfied with the results.
That is a staggering plummet. It's essentially a temporary scaffolding that looks great when it goes up, but eventually just collapses. And we really need to address the risks here too, because they are formally documented in adverse event databases and clinical case series. They might be classified as rare, but they are severe.
Very severe. The literature documents cases of persistent worsening pain during sex after laser therapy. Because as you noted, a controlled thermal injury is still an injury. In one very severe documented case, the healing process went wrong and resulted in a crescent-shaped fibrous band forming mid-vagina.
What does that actually mean for the patient physically?
It essentially created a partial obstruction, a stricture in the vaginal canal. Instead of becoming elastic and supple, the tissue scarred over. It became frail, rigid, and inelastic. It is the exact opposite of the intended goal, leaving the patient in more pain than when they started.
It's a stark reminder that we are dealing with a deeply complex ecosystem. You can't just zap it into submission without consequences. Now, lasers aren't the only high-tech devices being utilized. The clinical guidelines also dedicate a significant amount of space to transcutaneous electrical neuromuscular stimulation, or NMES.
Right, but this isn't for tissue dryness. This is strictly for treating urinary incontinence.
Exactly. This operates on a completely different biological mechanism. Instead of creating thermal injuries to build collagen, NMES uses electrical pulses to forcefully stimulate and contract the pelvic floor muscles.
Right, it can be administered via external surface electrodes or through an intravaginal or intraanal probe. The goal is to reduce stress incontinence, like, leaking when you cough or jump or urge incontinence, by mechanically exercising those muscles.
If you are listening to this and you've tried traditional Kegel exercises without success, this is where the clinical data gets really validating. You aren't doing it wrong. Sometimes the brain-muscle connection is simply too weak to even initiate a proper contraction. You need this forceful external electrical stimulation to literally wake the muscles up.
This is true.
But when I looked at the trial parameters for these devices, I was blown away by the sheer, unadulterated dedication required from the patients.
Oh, it is not a casual intervention at all. These clinical trials required patients to use these electrical stimulation devices for 20 to 30 minutes a day, 5 to 7 days a week, for anywhere from 6 to 12 solid weeks.
It's the equivalent of training for a marathon, but exclusively for your pelvic floor. Tell me that level of daily, time-consuming dedication actually pays off. Because if I am hooking myself up to an electrical probe 7 days a week, I expect a functional miracle.
Well, the results actually do justify the hard work. In a randomized controlled trial of 180 women, researchers used an objective measurement called a provocative pad weight test.
Let me guess, they literally weigh the absorbent pads before and after, making the patients do things that provoke leaks, like coughing or jumping.
That is exactly what it is. It removes subjective bias and gives a hard measurement of how much urine is actually escaping.
Smart.
And at the end of the 12-week regimen, over half the patients saw a 50% reduction in pad weight. That translates to massive, statistically significant improvements in their daily quality of life scores.
But again, look at the timeline. You don't plug this device in once, run a 20-minute cycle, and walk away cured. It takes weeks and weeks of daily, repetitive muscle stimulation to actually rebuild functional, load-bearing strength.
Exactly.
So if habits, localized hormones, laser therapies, and months of electrical stimulation don't solve the underlying structural issues, where do we go next? Because the guidelines don't just stop there. They point us straight to the operating room.
And this is where the conversation gets incredibly nuanced. Historically, pelvic surgery was strictly about functional repair, putting things back where they belong so the body can operate normally. But as we look at the current landscape, the line between vital functional necessity and cosmetic enhancement is getting very, very blurry.
Let's ground this by looking at the heavy-duty functional surgeries first.
For sure. The clinical data provides detailed outcomes on uterine suspension surgeries, specifically procedures like a psychohysteropexy. This is performed to repair severe uterine prolapse. Prolapse happens when the supportive pelvic floor tissues have failed so completely that the uterus literally drops down into the vaginal canal. To fix this, surgeons use a synthetic mesh to essentially hoist and permanently suspend the uterus back into its proper anatomical position.
It's like rebuilding a suspension bridge that has completely snapped. And the success rates for that kind of functional repair are wild. One trial reported a 95% overall satisfaction rate, with the vast majority of patients saying their symptoms were very much better. That is a major invasive intervention with a massive functional payoff.
It is. But when you look at the recent clinical trends, you see this massive pivot happening. We're moving away from just fixing what's broken into the incredibly murky world of cosmetic gynecology. Specifically, the literature highlights procedures like vaginoplasty, which is the surgical tightening of the vaginal canal, and labiaplasty, which is the surgical reshaping or reduction of the labia minora.
Here's where it gets really interesting, because the physical mechanics of a labiaplasty are highly specific. According to the surgical clinic protocols, there are two primary ways surgeons approach this. You have the trim technique, which is pretty much exactly what it sounds like. The surgeon cuts away a linear strip of tissue straight along the outer edge.
Right.
And then you have the wedge technique, where they remove a V-shaped triangular section from the middle of the tissue and then stitch the remaining upper and lower edges back together.
And what's fascinating here is the rationale behind the techniques. The wedge technique is often preferred by surgeons because it preserves the natural, original ridged contour of the labial edge. The trim technique removes that natural edge entirely, leaving a surgically straight line.
Right.
But regardless of the aesthetic technique chosen, we really have to talk about the physical reality of the recovery.
Yes. The timeline reality check. Because the clinic FAQs are very upfront about the brutal truth of the downtime.
You might think of it as a minor external day surgery procedure, but the labial area is highly vascular. That means it has a massive blood supply. When you cut highly vascular tissue, intense discomfort and extreme swelling are guaranteed.
Yeah.
The stitches they use are typically dissolvable, taking about 4 weeks to completely disappear. But the most critical takeaway from the surgical guidelines is the absolute restriction on physical activity.
We are talking zero heavy exercise, no running, no cycling, no heavy lifting, and absolutely no sexual intercourse for 6 to 8 solid weeks.
And even then, while the visible swelling mostly subsides in about 2 months, the clinical timelines state it takes a full 3 months for the deep tissue to achieve complete final healing.
Okay, I have to push back here. Are women really going through 3 full months of recovery, intense swelling, zero physical activity, and genuine surgical risk purely for aesthetic reasons to achieve some sort of socially conditioned perfect look? Or is there an actual genuine medical necessity driving these surgeries?
It is absolutely a mix of both. But we cannot dismiss the medical necessity because it's very real for a significant portion of patients. The clinical diagnosis is labial hypertrophy, meaning significantly enlarged labia minora.
Okay.
For women dealing with this, it has nothing to do with aesthetics. It is about severe daily physical pain. The excess tissue can chafe, pull, and even tear during normal exercise like running or cycling. It can cause intense chronic discomfort simply from wearing tight clothing or sitting for long periods.
Oh, wow. That sounds awful.
Yeah. For those patients, surgically removing that excess tissue is fundamentally about restoring their quality of life and eliminating daily chronic pain.
That makes total sense. It's functional repair disguised as a cosmetic term. But that perfectly bridges us into the final piece of our deep dive. Because the massive boom in these procedures has created a significant ethical dilemma that the clinical reviews heavily highlight.
Yeah, if we connect this to the bigger picture, we are seeing a rising global tide of aggressive marketing around cosmetic gynecology.
Yeah.
And a core ethical concern documented in the literature is that medical providers are increasingly marketing these procedures using highly misleading claims.
Yes, the infamous vaginal rejuvenation marketing.
Exactly. They are touting surgical reshaping or completely unapproved clinical methods as guaranteed ways to magically improve sexual function, boost libido, and enhance sexual satisfaction. The literature specifically calls out the rising interest in experimental treatments like PRP injections, often heavily marketed as O-shots.
Okay, so explain the theory behind that before we get to the data. How is an injection supposed to alter sexual function?
The theory sounds very cutting edge. Providers draw the patient's blood, spin it in a centrifuge to isolate platelet-rich plasma, which contains growth factors, and then inject that plasma directly into the vaginal walls and clitoris.
Right.
The marketing claim is that these growth factors will stimulate new blood vessels and nerve endings, thereby massively boosting sexual pleasure.
And what does the peer-reviewed clinical data actually say about that theory?
The ethical and clinical reviews are incredibly blunt. These injections are absolutely not FDA approved for treating sexual dysfunction.
They don't sound approved at all.
No. And their actual efficacy is highly debatable due to a severe lack of robust, long-term, placebo-controlled data.
It sounds like an attempt to solve a deeply complex human experience with a quick, profitable injection.
That is precisely the ethical warning the medical community is raising. Female sexuality is not a simple plumbing issue. It is incredibly complex. It is a delicate, intricate interplay of anatomical function, systemic hormonal balance, relationship dynamics, and deep psychological factors.
Yeah.
The idea that simply injecting blood platelets or surgically tightening a canal will magically equate to better sexual satisfaction is profound and potentially dangerous oversimplification.
And it's not just an oversimplification. It can actively backfire on the patient. The surgical guidelines explicitly warn that aggressively over-narrowing the vaginal canal through cosmetic vaginoplasty can lead to the exact opposite of the intended result.
Yes.
It can cause new-onset dyspareunia. Imagine going into a surgery hoping to improve your sex life and waking up with a surgical alteration that makes intercourse permanently physically painful.
It is a profound risk. And it is a risk that is far too often buried beneath glossy marketing brochures promising youthful rejuvenation.
So, what does this all mean? If you or someone you know is considering any of these procedures, whether it's a laser package, a daily electrical stimulation device, or a surgical trim, it is absolutely vital to separate the proven, peer-reviewed clinical realities from the aggressive marketing claims.
Absolutely.
You have to look at the 24-month data, not just the glowing 6-month satisfaction score. You have to ask yourself how a treatment works, not just what it promises.
And you have to honestly weigh the genuine functional need against external aesthetic pressure.
Which brings us to the end of today's deep dive. When we look at everything we've unpacked, whether it's waiting 3 full months for local estrogen to replump the cellular sponge, dedicating 12 weeks to electrically training your pelvic floor, or enduring a strict multi-month recovery after a surgical reshaping, the overarching theme is undeniable.
Completely.
Biology cannot be rushed. The body takes time to heal, to remodel, and to restore itself. There are absolutely no magic overnight fixes.
It requires immense patience, diligent compliance, and a realistic understanding of human biology. Which really brings us to the core of the issue. This raises an important question. As medical technology continues to advance at light speed, providing us with fractional lasers, synthetic mesh, and precision surgical reshaping, at what point does the medicalization of natural age-related bodily changes stop being about empowering women's health and start capitalizing on societal insecurities about aging?
That is a heavy, essential thought to mull over. Are we utilizing these incredible tools to fix genuine structural problems and eliminate pain? Or are we being sold a pricey, painful illusion to paint over the reality of simply growing older? We want to thank you so much for joining us on this deep dive. Keep questioning the claims you see, keep looking for the underlying mechanisms, and above all, treat your body with the profound patience it deserves. Because as we learned today, the real work of restoring your biological foundation happens deep beneath the surface, and it is never, ever an overnight job.